Hey everyone, welcome to This Explainer. I'm absolutely thrilled you're joining me, because today we are diving headfirst into what is essentially a high-stakes medical detective story. Picture this. A newborn baby has just entered the world, but instead of that strong, healthy first cry, they are really struggling to breathe. As clinicians, or really anyone studying neonatal care, the clock is ticking. You have to figure out exactly what's going wrong in those tiny lungs, and you have to do it fast. So today, we're going to crack the case on the two most common culprits behind neonatal respiratory distress.
Now, to solve this mystery quickly, we lean on a classic rule of two framing. When a neonate is in distress, we have to immediately ask ourselves one fundamental question. Is the infant's struggle caused by a critical lack of surfactant, or is it just leftover fetal fluid trapped in the lungs? Pretty much every single clue we uncover today is going to point us down one of these two distinct pathways.
So here's our clinical roadmap for This Explainer. We're going to hit 5 key areas. First, defining the distress. Then, spotting the clinical clues. Moving on to management protocols, anticipating the complications, and finally, looking at the final prognosis.
All right, let's jump right into part 1, defining the distress and identifying our main suspects.
Suspect number 1 is respiratory distress syndrome, or RDS. This kicks in when there's a critical shortage of pulmonary surfactant. That's the soapy substance pumped out by type 2 pneumocytes. Without it, the surface tension inside the tiny air sacs of the lungs just skyrockets, causing the alveoli to completely collapse every single time the baby exhales. To put that in perspective, a staggering 44% of extremely low birth weight infants, we're talking babies weighing between 501 and 1,500 grams, will develop RDS. Oh, and interestingly enough, it's significantly more common in males.
Then we have suspect number 2, transient tachypnea of the newborn, or TTN for short. This is totally different from RDS. It's not a structural failure or a lack of chemicals. It's literally just leftover fluid. You see, babies don't breathe air in the womb. Their lungs are full of liquid. Normally, the physical stress of birth literally squeezes that liquid right out, but sometimes it just gets left behind. If a baby is delivered via C-section, especially an elective one where they bypass that birth canal squeeze, their risk for TTN shoots up. Other risk factors include maternal asthma, diabetes, or smoking.
So how do you tell them apart? Well, gestational age is going to be your absolute biggest clue here. RDS is overwhelmingly a disease of premature infants, right? Their lungs just haven't had the time to mature yet. Honestly, you'll rarely see RDS in a full-term baby unless they've gone through severe hypoxia, acidosis, hypothermia, or if they are infants of diabetic mothers. On the flip side, TTN is the most common cause of self-limited respiratory distress in full-term neonates. It's a completely different demographic. Okay, moving on to part 2. Spotting the clinical clues through chest X-rays and physical symptoms.
When you're trying to nail down a diagnosis, the chest X-ray is one of your most powerful tools. With RDS, you get this incredibly vivid, honestly terrifying visual, the white lung. Since the alveoli are collapsed and there's no air, the X-ray shows this diffuse ground glass appearance. It's a reticulogranular pattern that totally obscures the heart border, leaving these dark, stark air bronchograms. It's super dense. But TTN, it looks entirely different. You'll see prominent perihilar streaking, which is really just lymphatic engorgement from the trapped fluid, plus fluid in the lung fissures. Crucially, though, the lungs are hyperinflated. TTN lungs actually have air. They just also have some trapped fluid to deal with, along with mild cardiomegaly and maybe small pleural effusions.
Beyond the imaging, the physical symptoms are a massive giveaway. You really want to contrast the violent physical struggle of RDS against the presentation of TTN. An infant with RDS is going to show severe chest recession, subcostal, intercostal, suprasternal. Basically, they are pulling with every single muscle just to open those collapsed air sacs. You'll hear expiratory grunting, you'll see cyanosis, and their blood gas, it'll show hypercapnia, meaning dangerously high CO2 and a low pH. TTN, however, gives you what we call a quiet tachypnea. Sure, they're breathing super fast to clear the fluid, but their chest actually sounds remarkably clear when you listen. No rales, no rhonchi. It's a much milder, quieter distress.
That brings us to part 3, the management protocols and how we deploy our countermeasures.
For RDS, the management protocol is strict, it's urgent, and it's highly structured. Step 1, immediate initiation of CPAP right in the delivery room. We want to try and keep those alveoli open with continuous positive pressure. Step 2, if CPAP just isn't cutting it, we go in with multi-dose exogenous surfactant directly down an endotracheal tube, usually every 6 to 12 hours. Step 3 is meticulous supportive care. We're talking warmed, humidified oxygen, strict incubator temps, minimal handling to reduce the baby's stress, and IV nutrition.
And keep in mind, mechanical ventilation is our heavy-duty fallback if the CPAP fails.
15 minutes. 15 minutes of life. That is our absolutely critical window. If you know you're delivering a severely premature infant at high risk for RDS, 15 minutes is your target window to deliver prophylactic exogenous surfactant. It is an incredibly tight time frame. If you miss that window and the infant develops RDS later, you can still give rescue doses, but ideally, those need to happen within the first 2 hours of life.
But you know, all of this perfectly illustrates a golden rule in medicine. The absolute best management is prevention. If we know a preterm delivery is coming between 24 and 34 weeks, we give the mother betamethasone. This involves 2 12-milligram intramuscular doses, spaced 24 hours apart, given 48 hours before delivery. This steroid is amazing. It crosses the placenta and dramatically accelerates the maturation of the fetal lungs. It literally stimulates those type 2 pneumocytes to start making surfactant before the baby is even born.
Now let's look at part 4, anticipating the complications, or basically dealing with the fallout. The complications of RDS are frankly intense, and tragically, a lot of them are iatrogenic, meaning they're actually caused by our medical treatments. Endotracheal tubes can cause trauma or stenosis. Umbilical catheters can become malpositioned or even perforate delicate vessels. Because we're having to force pressure into these stiff, unforgiving lungs, these infants are at extremely high risk for catastrophic air leaks between days 2 and 7. Think pneumothorax or pulmonary interstitial emphysema. Systemically, that lack of oxygen can cascade into brain bleeds, pulmonary hemorrhages, and cardiac issues like a patent ductus arteriosus.
If the infant manages to survive the acute phase, but still needs long-term mechanical support, we run into a major roadblock: bronchopulmonary dysplasia, or BPD. This is a severe, late-stage complication. If a baby is stuck on supplemental oxygen for more than 28 days, the sheer combination of high oxygen levels and mechanical pressure essentially scars that developing lung tissue. It leads to a chronic lung disease that can impact their health for years to come.
Finally, we arrive at part 5, the final prognosis and the timelines of recovery.
Let's map this all out temporally. At the 15-minute mark, we have our prophylactic surfactant window for RDS. Fast forward to 72 hours, and TTN, remember, that's the milder leftover fluid condition, well, that has usually spontaneously resolved with little to no need for oxygen. But at 96 hours, that's when RDS is often at its absolute worst. It peaks right before a sudden, brisk diuresis, basically a major release of urine, which is the ultimate signal that the infant is finally turning the corner. And of course, at the 28-day mark, we hit that danger threshold for BPD.
Despite all of that, I want to leave you with a really reassuring number. Even with the terrifying clinical presentation of RDS, the violent chest recessions, and that massive list of scary complications, modern medicine is just incredible. Thanks to antenatal steroids, CPAP, and exogenous surfactant, the overall survival rate for RDS is now greater than 90%. And the best part? Most of these infants go on to have a very good long-term pulmonary outlook.
Which brings us to our final thought for today's explainer. We've just seen that if just 2 doses of antenatal steroids can radically alter the course of RDS before birth, imagine what's coming next. How might emerging therapies and technologies completely eliminate the need for mechanical ventilation in premature lungs in the future? The science is evolving so rapidly, and every single new discovery brings us closer to making neonatal respiratory distress a thing of the past. Thank you so much for joining me today, and keep asking those big questions.